So this is a left knee arthroscopy. Apparently this gentleman had a left knee arthroscopy by an outside surgeon at an outside institution about 20 years ago and has developed recurrent pain in the left knee, predominantly on the inside of the left knee. MRI was performed as equivocal for a recurrent tear of the medial meniscus. So we'll see what we're dealing with. Sometimes it's hard to assess on a MRI after arthroscopy whether or not there's a tear, because it's hard to contrast the findings with post-surgical changes. So here we're going to make an incision starting again at the level of the joint line. Go into the knee.
42 for start time?
Correct. Thank you.
Get that water running. Clear out the joint. And start our diagnostic arthroscopy. Look underneath the kneecap. Cartilage looks great. And then popping into the knee joint on the inside of the knee, the medial compartment, where he had his previous work done. 18 gauge spinal. And just like I saw in the MRI, right at the junction right there of the posterior horn of the medial meniscus in the body, so there's my trajectory with the 18 gauge spinal needle getting into the joint, making sure I can evaluate that area. 11 blade. But on the preoperative MRI that I reviewed just before the surgery, I saw a probable recurrent tear at the junction of the posterior horn and body. There's the anterior cruciate ligament, nicely intact. Looks like he's had some cortisone injections in the past. You see some of the precipitation. I'm going to go into the lateral compartment, looking at that triangle again formed from the lateral femoral condyle, lateral border of the anterior cruciate ligament and the anterior horn of the lateral meniscus, then placing the knee in a figure 4 position, easily getting into the lateral compartment open close, and you can see it looks perfect. Again, some precipitation of the probable depomedrol injections versus a condition we call CPPD, chondrocalcinosis. Lateral compartment looks perfect. Hopefully by now we're good. I'm going back into the medial compartment. Okay, should be good? All right, short blunt. Yeah, so you can see it opened up right now. So it should be relatively easy for me to address this pathology. You can see a flap of the meniscus. Now you can see I'm getting underneath that medial femoral condyle without causing any articular damage. Now you can see a little flap right there. See it? You'll see it pop out in a minute, right there. That's his problem. In the office, when patients are diagnosed with meniscus tears, I always give the analogy of sort of a hangnail. We're doing the arthroscopic procedure not to remove the whole meniscus, but just the part of the meniscus that's torn, very much akin to a hangnail, where you take a nail clipper and you just clip the part of the nail that's torn so the whole nail doesn't rip off. Okay, so here we're done. You can see we did the partial meniscectomy. We removed just that hangnail. This is all stable, one piece. Let's just look at the rest of the trochlea. And you can see that after I removed some of the synovial tissue, I could see some arthritis or chondromalacia of the trochlea. So that may cause some pain in the front of his knee, right there. That's the trochlea of the distal femur. And the kneecap articulates with that. And you can see it, but it's, again, it's a very small lesion. For the most part, he's got a beautiful looking knee. and we're done.